Hi, I'm Joe Roth. At New Jersey Sharing Network, we're committed to saving and enhancing people's lives through organ and tissue donation and informing people about our life-saving mission. That's why we're proud to support programming produced by the Caucus Educational Corporation and their partners in public television.
Funding for this edition of One-on-One with Steve Adubato has been provided by the Healthcare Foundation of New Jersey, founded by the Jewish community, TD Bank, the New Jersey Education Association, PSE&G, committed to improving New Jersey's economy and strengthening its communities, New Jersey Sharing Network, dedicated to saving lives through organ and tissue donation, NJM, auto insurance, homeowners insurance, and more, with a focus on safety and financial stability, and by the Russell Berry Foundation. Promotional support provided by The Record, North Jersey's trusted source, and NorthJersey.com. And by Meadowlands Regional Chamber, building essential connections that drive business growth.
This is One-on-One. I'm an equal American just like you are.
The jobs of tomorrow are not the jobs of yesterday.
Look at this. You got this?
Here it is, man. Look at that.
Life without dance is boring.
When you first heard that they were doing Charlie Rose and Gayle King, didn't you go, what?
Do you enjoy talking politics?
No. People call me because they feel nobody's paying attention.
Our culture, I don't think, has ever been tested the way it's being tested right now.
Such a good question. High five.
Welcome to One-on-One. I'm Steve Adubato. It is my pleasure to introduce Dr. Am Barrett, who is Director of Stroke Rehabilitation Research at Kessler Foundation. Good to see you, Doctor.
It's great to be here.
You are a cognitive and behavioral neurologist and a neural behavioralist.
Exactly, a
What does that mean?
neurorehabilitationist. Yeah, well, neurologists can train in a number of different specialties, and I couldn't make up my mind between whether I wanted to study behavior or rehabilitation, and so I do a little bit of both.
And so your research focuses on brain-behavior relationship, the relationship between the two. What does that mean?
Well, we can think about designing rehabilitation for the parts of the brain that are injured. So, you know, for example, most of us think about stroke and brain injury as being something that causes a visible disability like paralysis.
Right.
And there's really, the brain-behavior relationship is just a small area of the brain that takes care of movements of the arm and leg. But we have these big swaths, big areas of the right brain, and their job is really to help the body to have a relationship with the external world, kind of an internal GPS or a compass.
An internal GPS. Go ahead.
Exactly. Something we use to map where things are in our environment. You know, so for example, when I do something as simple as putting my glasses on, I can do that, I hope, without making any kind of an error because I have kind of a three-dimensional representation of what my glasses are and this movement and my head. But if I had a problem with the right side of my brain, this system, this spatial system, may create a distortion so that I make an error with even these very simple tasks. And it's tragic because it's a hidden disability. It's not something people can see.
Hidden because I can't see what is wrong with you, if I can put it that way, because it's in your brain?
Exactly. So when I have my glasses on in this way, what often might happen is that the family member or the professional caregiver even might assume that I have an intellectual issue or a problem with, you know, not being motivated or my personality, rather than knowing that I have this GPS, this compass problem that's keeping me from using three dimensions in the normal way.
So sometimes people misperceive, misunderstand, think that person's sometimes lazy.
Exactly, because they don't know why the person doesn't correct his or her errors.
Like what's wrong with you?
Exactly.
And you've brought in these goggles. What are they called?
These are Prism Goggles.
Prism Goggles.
Yeah.
Now,
Yeah.
these Prism Goggles reflect what it would look like if someone was dealing with one of these issues?
They can simulate the kind of distortion that someone will experience, but they also are used for therapy. So in this brain-behavior relationship we were talking about before, they can be used to prescribe a very specific treatment for this right brain problem, spatial neglect. What we do is we have people wear these goggles for about 10 minutes, 15 minutes a day. They make movements. The goggles displace what they see. So if I'm looking at something that's straight ahead of me, it actually looks like it's displaced to one side if I'm wearing the goggles. So the goggles, as you can see, kind of have this prism, this prismatic wedge. And so just like as if I were reaching into water, they make what I'm seeing.
Should I look in there?
Move over. Absolutely. Go for it.
So,
You want me to borrow one of your pens and I can show you
Please.
this? Great.
my favorite purple pen.
Excellent.
Go ahead.
All right, so I want you to go ahead and, can you hold that with your left hand? And I want you to go ahead and touch your chest with your right index finger. And go ahead and touch my pen if you would. Good. Good, you did beautifully. Touch your chest again. I want you to do it faster this time. See, now you're going a little bit off to the right side, which is normal. Now, keep doing it, yep. And as you continue to do it, what you're going to do is do it completely accurately, right? Exactly. But now what's happened is that your brain has learned a new relationship between what you see and where you're moving. And that would correct this hidden functional disability or vision. So now what we're going to do is ask you to just go ahead really quickly, touch your chest with the goggles off, and you can keep the goggles off, great. And now go ahead, quickly touch the pen. So the first time is probably because you have such a good system, it was a little bit off to the left side, because your brain had remapped, and then it went away.
Say that again, my brain had remapped.
Exactly. So
my GPS was different?
Exactly, without my even telling you so. Well, that's what's beautiful about using this as a therapy, is I don't have to tell you to do anything. Again, I don't have to believe that you're going along with me or you're motivated. I can just ask you to go ahead and make these movements. I'll return your pen to you.
Sure.
And if you do that for 15 minutes a day for 10 days, what will happen is that your system will automatically start to correct the way that it moves. People will be able to dress themselves properly, sit up properly. They'll be able to effortlessly find their loved ones' faces.
Is it comparable? You've told our producers that it's sort of like you're trying to grab for something in water.
Yes. Yes, it's like the problem that these people have is that their visual spatial world is distorted.
They wear it for 10 days. 15 minutes a day.
15 minutes a day.
What have you seen?
Well, what we've seen, so these people, some of them are some of the most vulnerable people after stroke and brain injury, right? So these folks are about 6.5 times more likely to fall. They stay in the hospital, more likely to fall while they're in the hospital. And this is a big issue, right? It can lead to injury, all kinds of ill events. They're about 45% less likely to go home, even though they stay in the hospital longer, about 10 days longer, so a long time. So these people, when they receive this treatment, we do see that their ability to get up and use a walker to transfer to walk again improves. And it's not just us, a number of different centers in Europe, in Japan, all over the world are using this technique.
Why and when did you become so fascinated with the connection between the brain and our behavior?
Well, probably when I was before I went to medical school, I had the opportunity to study in a center in Boston where there were a lot of people who had had brain injuries. And, you know, it was very clear to me that people weren't different as people, but that their ability to do things was different and that they were seen differently.
And there are how many people, you think, suffering and dealing with these problems?
About 300,000 after stroke. So that's about the population of Newark, right? About a little bit more than
300,000.
Yeah.
Georgette, show the picture that we're about to see. Doctor, you can talk about this. Take a look at the picture. Explain that real quick.
Right. So on the left side, we can see a star and a cube, and you and I can see both sides.
Sure.
But the person who has this problem after right brain stroke, what that person sees and what we could see them actually draw if one of them were here with us, is they only see the right side of this. So their world is just missing a piece.
And your research is going to break new ground as you move forward and try to continue to help these folks.
Yeah, we hope that we'll help people identify them. Most of them are not identified when they're in the hospital, and then assign the right treatments to them.
Dr. Am Barrett, who is the Director of Stroke Rehabilitation Research at Kessler Foundation, and I want to thank you for joining us. We appreciate it.
Thank you so much.
Important work. Stay with us. We'll be right back right after this. That's fascinating.
To see more one-on-one with Steve Adubato programs, visit us online at steveadubato.org. If you would like to express an opinion, email us at info@caucusnj.org. Find us on Facebook at facebook.com/Steve Adubato PhD, and follow us on Twitter at Steve Adubato.
Dr. Raul Parra is Medical Director, Regional Cancer Center, Holy Name Medical Center. Good to see you, Doctor.
Nice to have you.
You're here to talk about prostate cancer.
Yes.
I said to you right before you get on the show, I said, so 1 in 7 men dealing with the prospect of prostate cancer in a lifetime. You said, no, 1 in 6.
Correct.
That common?
Yes.
Who's most susceptible?
Well, every man eventually will have some form of prostate cancer if they live long enough.
Is that true?
Yeah, it's true.
Why is that?
Nobody knows, but it's probably genetic. It's a combination of genetics and hormonal and predisposition. And it's just a fact of aging may predispose you to develop certain types of cancer, and prostate cancer is the most common cancer in men.
Who should be tested and when?
That's a good question. There's been a lot of controversy lately because of PSA screening.
The PSA screening, the test.
Correct, which is an acronym for prostate-specific antigen, which is basically a protein in that is detected in your blood that is secreted by all prostate cells, but is higher when there is a cancer in the prostate.
So, men ages 50 to 70. Mm-hmm. Is it fair to say that that is the age group most susceptible?
Correct. Actually, it depends also on your race and on your family history.
Race and family history, break that down.
Yeah. The risk factor for prostate cancer, aside from age, is if you're African American or have a family history of prostate cancer in which either your father, your uncle, or one of your brothers has been diagnosed previously with prostate cancer, places you at a higher risk of developing prostate cancer earlier and possibly with a more lethal type of disease.
Why?
That's unknown. Really.
It is unknown.
It is unknown, but there's a lot of new developments, and it looks like it's a genetic predisposition in which mutations occur at a cellular level that predispose some men to develop this disease.
Doctor, go back to the African American men issue. You said that African American men are more susceptible. I hope you're not going to tell me we don't know why. Do we know why?
No, we don't know why.
We don't know, we have no idea.
No idea. There are some inclinations that it may have to do the way that certain hormonal changes occur, some genetic predisposition, which there may be some genes related to it. And in the past, people thought that because of the pigment in the skin.
The pigment?
Yeah, you would not.
Is that clinically proven?
No, it hasn't been proven. But, you know, a lot of these things are suggestions that have to be totally proven. But in reality, I think it's also been a fact that African American men in the past had less access to early detection than the counterparts.
Talk about this part of it. Early detection is key, but also monitoring is key.
Yes.
Talk about that.
Well, monitoring is really, once you have a PSA test done, I like to define it that way. I think it's very important that men, in my opinion, I know goes against a little bit of what the task force has recommended. I don't know if you read that the recommendation by the U.S. task force on PSA.
Which, the U.S. task force, like the federal government got into this?
Yes, and they created a panel in which they reviewed the data that was available. By the way, there were no urologists in the panel.
Hold on, no urologists who sat on the federal government's panel on prostate cancer?
Correct.
I don't even know what to do with that, but go ahead.
I don't either. But the recommendation was that based on the data available, there was no benefit in testing men for prostate cancer, that the harms from early detection far outweigh the benefits. On the other hand, I think that we have to use judicious screening. And the recommendations by the American Urologic Association is that men under the age of 40 really have no benefit in early detection. But however, we should probably obtain a baseline PSA around 45.
45 baseline?
Yeah, 45 baseline.
How often after that?
If your PSA is less than 1, you should probably wait 10 years and get it tested again.
If it's higher?
If it's higher, between 1 and 3 every other year.
Higher than 3?
And higher than 3, you should have a biopsy.
You should?
Yes. If you start getting older, by the age of 75, probably it's not worth getting a PSA.
Why?
Because a lot of men at the age of 75, even if you detect prostate cancer, they're probably going to die of something else.
I shouldn't laugh, but you're probably going to die of something else.
Yeah.
By the time, do this in the time we have treatments. How are they different? If you have it, it's got to be treated. How has it changed?
There's a lot of improvements in treatment. For younger men, those men who have a life expectancy of a minimum of 10 years, we recommend surgery. And most of the surgery is done now at robotic, in which the functional outcomes are excellent. And there are other methods that have improved also, such as radiation therapy. And even in men with very advanced prostate cancer, there are new medications available that actually prolong life and actually, in some instances, actually cure patients.
You've seen tremendous progress in this field.
Yes.
How many years have you been in it?
Over 34.
I need to ask you this. Why did you decide this field?
Why?
Yeah.
I thought it was extremely interesting when I was going to be a cardiothoracic surgeon. And because everybody that was a surgeon in those days, I have to operate on the heart. But when I rotated in cardiothoracic surgery, I didn't like the type of lifestyle, the type of surgeons that were there. And I rotated with the urologist. And I said, this is a common guy. And I liked it. And I liked the cancer field, and I like cancer surgery.
Dr. Raul Parra is a medical director, Regional Cancer Center at Holy Name Medical Center. Doctor, I want to thank you. It's very important information that everyone needs to be thinking about, particularly the men out there, regarding prostate cancer and protecting ourselves and staying on top of it, particularly men of a certain age. I've heard that before. Thanks,
Right.
Doctor.
Thank you.
Stay right there. We'll be right back right after this.
To see more one-on-one with Steve Adubato programs, visit us online at steveadubato.org. If you would like to express an opinion, email us at info@caucusnj.org. Find us on Facebook at facebook.com/Steve Adubato, PhD, and follow us on Twitter at Steve Adubato.
We're pleased to welcome Linda Schwimmer, who is President and CEO, New Jersey Healthcare Quality Institute. Good to see you, Linda.
Good to see you. Thanks for having me.
You've joined us on our sister program, Caucus, New Jersey.
Yes.
Different discussions, but I want to talk to you about the Affordable Care Act. You've actually said that we need to improve it. We can improve it. We don't have to scrap it. Some people talk about doing that. You say, hey, there are pros and cons. Let's improve it. How? Let's improve it.
Right. I think we can improve it. I don't think we should scrap it. New Jersey has a long history of being innovative in healthcare. Back in 1993, we actually had an exchange for individuals and small employers. We actually said a long time ago that it's not fair to price healthcare based on the health status of an individual, which was a pretty innovative, progressive thing to do.
You're talking about pre-existing conditions.
Right, exactly. Pre-existing conditions, not blocking that out, or even charging based on someone's healthcare status, which was allowed in some states. So if you had a condition, you could actually be charged more. We said for a long time that's not right. There's certain things that you can charge on, such as age. But other than that, healthcare is a fundamental need that people have, and we have to make sure that people are able to get care.
Is it a right?
I think it is a right. Yeah.
You do?
I mean, it really is a matter of life and death.
Healthcare is a right.
I think so. It's a matter of life and death. I think that in an open society where we, particularly in a democracy, in a capitalist democracy, where we want people to be able to live and support themselves and their family, how do you do that if you're not healthy or you can't get the care that you need?
Talk about improving a little bit more specifically. What should be done with the Affordable Care Act,
So
otherwise
I think,
known as Obamacare?
Right. I think going back to that question you just asked, is it a right? I think it's a right, but it's not an unlimited right. So it's not an unlimited resource. We can't afford to give everybody absolutely everything that they might want, because what happens is if we keep spending more and more on healthcare, we start to crowd out everything else. We're seeing that now at the national level. We're seeing that here in New Jersey. We spend more on healthcare, and then what that means is we have flat wages. People don't hire more employees because they can't afford to pay them benefits. We can't afford to fund our schools. We can't afford to hire new teachers, et cetera. You know, it just crowds
What does that have to do with the
everything out.
ACA, the Affordable Care Act?
Well, the Affordable Care Act, since the Affordable Care Act was passed, there's been a real focus and energy and, frankly, innovation on ways to reduce costs and to improve quality. So things like looking at the waste in the system, looking at what's a more appropriate use of these resources, looking at, say, more integrated care, having primary care providers who you are connecting with, who are reaching out proactively and saying, you need to come in, I haven't seen you, let's take some tests, let's make sure you're on the right medication, and then having a conversation with their
But
patients.
Linda, let's do this, Linda. Let's bring it down a little closer to the consumer
Okay.
in terms of improving the Affordable Care Act. Is it also fair to say that one of the problems with it is that people still struggle to understand it, and that if they go on the so-called exchange, if they go on healthcare.gov during a period of time where you can purchase one of the plans, that it's still unnecessarily confusing, complicated, and they're having a hard time with it?
Yes, I think
so. Is that part of the problem?
That is part of
with
the
the
problem.
Affordable Care Act.
That's part of the problem is that when you go on to healthcare.gov, especially in New Jersey, because we have the federal system.
Let's make it clear: the state did not step in and say, "We'll take this over." Governor Christie said, "No, feds, you do this."
Right.
Some states said, "We will take it over." On the state side, that's not what Governor Christie decided.
Right. So we're part of the federal system. We use healthcare.gov, and healthcare.gov has gotten a lot better in the 3 years it's been in existence, and hopefully it'll continue to improve, but it needs tools for consumers.
Such as?
Okay, so some of the other states have this, and the state-run exchanges, and there's lots of apps that are in development around this. What we need is something like this. I go in as the consumer, I plug in, here are the doctors I want to see, here's the medication, here's what my income is, here's a general sense of how much savings I have and my risk tolerance, right?
What does that mean, my risk tolerance?
So,
I'm on the stock market.
Well, it's kind of like that, though,
really?
Right? It's kind of like if you were, it's kind of like with like auto insurance, right? You can pick a $500 deductible because you want to know for sure that most things are going to get covered, or you can pick a $2,500 deductible because you know I've got savings, I'm a really safe driver, I'd rather pay less premiums, and if I do get in an accident, I'll have to pay more out of pocket. It's a similar kind of analysis with healthcare in that.
Respectfully, and I'm sorry for interrupting, why can't I just know how much a procedure is going to cost and then make a decision?
So that's that.
Wouldn't it be more transparent?
So that is one of the hugest problems with healthcare you just hit on, is that we are still not at the point today where you can go into a doctor's office or you can go into a surgery center and say, how much is this procedure going to cost, soup to nuts? Because you're going to get a hem and a haw, and they can tell you what they will charge you, but they can't tell you what every single other provider in the chain of the process is going to charge.
Well, how am I going to make a decision about whether I'm going to move forward on this procedure? See, I understand us saying, I recently had some dental work done. This particular procedure wasn't covered, okay? Right?
Right.
But I asked the dentist, how much? Because that's the number.
Right.
I decided it was worth it. Cosmetically, it was worth it.
Right.
If I didn't think it was worth it, I wouldn't do it. But my point is, isn't that important information to know?
That's absolutely important information to know. And we have a real void here in New Jersey. We don't have...
Is it just New Jersey?
It's not just New Jersey, but New Jersey is worse than a lot of other states on that. And one of the reasons why is we don't have requirements for reporting that information. We don't have what's called a claims database or an all-payer claims database where this information is available to consumers, to researchers, to app developers, to start creating tools that we can use.
Could we have something like that?
We absolutely could have something like that.
What's standing in the way of that?
What's standing in the way
Seriously.
of that is honestly vested interests who have that information and view it as market power for themselves, and they don't want to share it, and the lack of laws and regulations requiring it.
How much of this is political will or the lack of political will on the part of government leaders?
A large part of it is. I think there are government leaders that are pushing for this, and I think eventually they're going to be successful because the only way the Affordable Care Act will work is if people have more information.
So if insurance companies, hospitals, and government officials came together and wanted this, any reason why it wouldn't happen?
No.
Those are the players.
Absolutely.
Did I miss anyone?
Pharmaceutical companies.
What do they have to do with it? Because of the drug prices?
That's right. That's right.
All right. Give us a reason to be hopeful, because listen, I hear people say, get rid of the ACA. That's not a solution in your mind, right?
Right. I think that we can continue.
People running for president say that on a certain side. That's
Right.
not a solution in your mind?
That's not a solution, because how are people going to get the health care that they need? Going back to the point that it's a right and it's something that we need to have every day. It's not a solution. And just to say...
Even if it's imperfect?
Even if it's imperfect, just to say we're going to throw everybody into a risk pool. What does that mean? Or to say that we're going to decouple it from employment, which is what some people are saying. Okay, fine, but then who's going to pay for it? If you look at the ACA, right, almost everybody who's newly covered under the Affordable Care Act, that's being paid for by government.
Minute left. I've heard some people who see themselves as free market advocates. You got a few seconds left. Let the free market decide, you say? Let the free market decide the whole healthcare system. You don't need the government involved, you say?
We're not talking about jeans and hamburgers and things like that. We're talking about something that people need to survive. I think that with something as critical as that, there's an important role for regulation.
Government has to be involved.
Absolutely.
And industry, hospitals, healthcare, insurance companies,
right.
Health insurance companies, and pharmaceuticals have to be involved.
And employers.
And by the way, the New Jersey Healthcare Quality Institute looking over all of this and trying to make sense of it for consumers. Linda Schwimmer, who is the president and chief executive officer of that very solid organization. I want to thank you for joining us and breaking down a complicated but important topic. Thank you, Linda.
Thank you.
One-on-One with Steve Adubato has been a production of the Caucus Educational Corporation, celebrating over 25 years of broadcast excellence. Funding for this edition of One-on-One with Steve Adubato has been provided by the Healthcare Foundation of New Jersey, TD Bank, the New Jersey Education Association, PSE&G, New Jersey Sharing Network, NJM, and by the Russell Berry Foundation. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area.
Seeing science in action makes students realize they can learn.
What is that word now called? Elizabeth.
With the right tools, it's easy to motivate students.
Students need to know science to succeed in the global economy.
That's why NJA established the Center for Teaching and Learning.
To give teachers the training to make science come alive and to keep New Jersey schools among the best in the nation.
That's why we are so proud
to teach in New Jersey's public schools.